I'm Carla Pecoraro.
I'm Anne Woolfield.
And I'm Mel Akerman, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things O&G. Following on with our series of perinatal infections, today we'll be discussing the R in the torch infections.
Whoa, hold up. Last week we did T for toxoplasmosis. What happened to the O?
Well, if you must know, the O stands for other, which basically means any other infection that's not toxoplasmosis, rubella, CMV, or HSV. Typically, the O includes infections like syphilis, HIV, parvovirus, varicella zoster, and even Zika virus. Because going into all of these would ruin the very neat system we are currently following, we're just going to jump straight into rubella and leave these ones until later. So, what is rubella?
Rubella is a highly contagious viral illness, also known as German measles. It typically presents with mild flu-like symptoms and a rash, although up to 50% of people with rubella can be asymptomatic. The classic presentation of rubella is a mild fever, conjunctivitis, sore throat, cough, and malaise. These symptoms usually last for 1 to 5 days and are followed by the onset of a red rash. The rash starts on the face and spreads within hours to the trunk and usually lasts for about 3 days. Patients with rubella might also experience Forchheimer spots, which are small red spots on the soft palate and lymphadenopathy at the back of the head, behind the ears and in the neck. Rubella is typically mild in children, but can be more severe in adults, leading to symmetrical arthralgia and arthritis, post-infection encephalopathy, and thrombocytopenia. Treatment is typically just symptomatic. There's no medication to treat rubella.
Ah, yes, Forchheimer spots and lymphadenopathy. These are key points to remember. I feel like they always seem to pop up in multiple choice questions about rubella. Okay, so how is rubella spread?
Rubella is spread through droplet transmission or through direct contact with nasopharyngeal secretions. So basically, whenever a person coughs or sneezes. People with rubella are usually infectious for about 2 weeks, starting 1 week before the rash appears and then 1 week after. The incubation period is 14 to 21 days. Interestingly, babies with congenital rubella can be contagious for over a year.
So why do we care about rubella in pregnancy?
Rubella is not usually dangerous to the person it infects. However, if you happen to get rubella in pregnancy, your baby is in a fair bit of trouble. Rubella infection can result in multiple pregnancy complications, including miscarriage, fetal infection, stillbirth, or intrauterine growth restriction. It's also known to cause some serious congenital defects, with the classic triad being sensorineural hearing loss, cataracts, and heart defects. Rubella is the leading vaccine-preventable cause of birth defects, accounting for 100,000 infants being born with congenital rubella syndrome worldwide every year.
If rubella is generally such a mild illness in adults, how did we find out that it was associated with congenital rubella syndrome?
Well, it's an interesting story, and once again, Australia gets to take the credit. It all started with a pediatric ophthalmologist called Dr. Norman Gregg. In 1941, Dr. Gregg observed a cluster of babies born with congenital cataracts and other eye defects. Now, he happened to overhear some mothers in the waiting room discussing how they thought their child developed the cataracts, and it was actually the mothers who said that they wondered if it was from the rubella infections that they both had in early pregnancy. Fortunately, Dr. Gregg was a bit of an eavesdropper, and he took this suggestion seriously and then decided to do an epidemiology study, which revealed an alarming association between rubella infection and congenital cataracts. From there, more research followed, demonstrating the association between rubella infection in pregnancy and congenital defects, which led to the development of the rubella vaccination.
Whoa, Dr. Gregg, what a legend. Although really, I think we have to thank those two mothers. Got to trust those motherly instincts. So let's dive into this a little bit more. What happens when a pregnant woman becomes infected with rubella?
Well, as we've mentioned before, the woman might have mild flu-like symptoms, or she might even be asymptomatic. About 5 to 7 days after the woman becomes infected with rubella, the infection spreads to the placenta and then through the fetal blood, causing infection. This is called mother-to-child transmission. And the chance of a viral spreading to the baby actually depends on the timing of the rubella infection during the pregnancy. So infection in the first trimester carries an 80% risk of a fetal infection, Infection the rates drop a little bit in the second trimester. So an infection carries a rate of a 25% risk of fetal infection, and they skyrocket towards the end. So infection in the third trimester has a 100% risk of fetal infection. After infecting the placenta, the rubella virus spreads through the vascular system of the developing baby. This results in damage to blood vessels and ischemia in affected organs. Rubella causes birth defects through two proposed mechanisms: viral inhibition of cell division and direct cytopathic effects.
Now, there's one thing that is absolutely crucial when it comes to understanding the birth defects associated with congenital rubella syndrome, and that's the timing of a rubella infection during pregnancy. The severity and likelihood of birth defects due to rubella really depend on when in the pregnancy the infection happens. The most dangerous period is the first half of pregnancy, with the first 16 weeks being the highest risk window. And if you stop and think about it, this makes total sense. Here's why. In the first trimester, fetal cells are rapidly dividing and forming the organs that are essential for the baby's development. Since rubella affects cell division, it's easy to see how infection during this time could have a major impact, especially when organogenesis is in full swing.
So now let's break it down by organ system. The heart. The development of the fetal heart is complete by the 10th week of gestation. So if rubella infection happens before this time, it can result in cardiac defects. The eyes. The most critical period for eye development is between weeks 4 and 12 of pregnancy. Infection during this time can lead to eye defects like cataracts or retinopathy. Ears. Hearing development begins early and is largely complete by 18 weeks. So infection before the 18-week mark can cause deafness, which is one of the hallmark features of congenital rubella syndrome. So the key takeaways here: infection before 12 weeks, this is the most critical time for multiple defects, including heart and eye issues. Infection before 18 weeks, this is particularly linked to hearing loss, including deafness. After 20 weeks, organogenesis is complete. So while birth defects are unlikely if the infection happens after this point, rubella can still affect the size of certain organs and function of the placenta, which can result in intrauterine fetal growth restriction.
One important note, there is no evidence that rubella infection immediately prior to pregnancy increases the risk of congenital rubella syndrome. So if the infection happens right before conception, it doesn't seem to have the same impact as if it happens during the pregnancy itself. So the timing really matters. Early infection is far more likely to cause serious birth defects, while a later infection can still affect fetal growth, but is much less likely to cause major structural issues.
Okay, so now we understand the concept of congenital rubella syndrome, which is a group of birth defects that can occur when a pregnant woman contracts rubella, especially if she contracts rubella in the first trimester. But what exactly are these birth defects?
The typical features of congenital rubella syndrome are deafness, cataracts, and heart disease. But the rubella virus doesn't stop there. It can infect almost any organ, leading to a broad spectrum of physical and developmental issues. The 5 key features I like to remember are heart defects, eye defects, brain defects, microcephaly, and sensory neural deafness. Heart defects typically include a patent ductus arteriosus and pulmonary stenosis. Eye defects include cataracts, retinopathy, and microphthalmia, which is a condition where the eye is abnormally small. Brain defects include mental and psychomotor delay, as well as speech and language difficulties. Microcephaly means a smaller than normal head size, and sensory neural deafness refers to hearing loss, which is due to nerve damage.
And here's the kicker. Most infants with congenital rubella are actually asymptomatic at birth, but the signs and symptoms show up over time. Early manifestations might include fetal growth restriction, meaning the babies may not grow properly during pregnancy, sensory neural hearing loss, which may be present from birth or can develop as the child grows, CNS involvement like meningoencephalitis, microcephaly, developmental delay and motor delays, and even behavioural disorders, congenital heart disease with PDA and branch pulmonary artery disease being the most common issues, and eye disease such as cataracts, glaucoma, and retinopathy.
And then we've got those late manifestations that can show up in about 20% of kids with congenital rubella syndrome. These can include hearing loss, and this occurs in around 80% of these kids, and it's usually bilateral. The thing is, hearing loss may progress over time, or in some cases, a child may suddenly lose hearing years after having normal hearing. Then there's also endocrine disorders like diabetes, thyroid disease, and growth hormone deficiencies. There can be more eye problems like pigmentary retinopathy, glaucoma, cataracts, strabismus, and even microphthalmia. There's vascular disease, which can impact circulation. And then there's something a little bit scarier, panencephalitis. This can occur in the second decade of life and is a slowly progressive and fatal condition, with the initial signs often being learning problems and ataxia, a lack of muscle coordination.
Now let's please talk about infection control because congenital rubella syndrome is contagious. Newborns with congenital rubella are actively infected at birth and they remain contagious for quite a while, so droplet precautions are a must. Only people who are immune to rubella should be around these infants. And while vaccinated household contacts don't need to take extra precautions, anyone who's pregnant or may be around pregnant individuals should be advised of the risks. Children with congenital rubella syndrome are generally considered contagious until at least 1 year of age, unless 2 clinical specimens taken a month apart show no trace of the rubella virus by culture or PCR.
Okay, so hold up. I know we've just gone on about how big of a deal rubella can be in pregnancy, but I haven't ever seen a single patient with rubella. The last I heard of it was in an Agatha Christie novel. Surely this isn't an issue in Australia. Haven't we gotten rid of rubella?
Well, technically you're right, Anne. Australia was declared free of rubella in 2018, meaning that there is no ongoing local transmission of rubella within the population. Now, this was mainly due to widespread measles, mumps, and rubella vaccination in children.
Yay!
But that doesn't mean you can't get rubella in Australia. Rubella has not been eliminated worldwide, and so you can still get the infection from travelling or from people who have travelled overseas. There is actually a pretty good system in place to detect cases, and any cases of rubella are considered notifiable. Testing for rubella immunity before pregnancy and vaccinating if needed is important for protecting women and their unborn children against rubella.
And how do we test for rubella immunity?
Rubella immunity should be screened for with the pre-pregnancy bloods by performing a rubella IgG. Importantly, we don't order rubella IgM unless we are specifically looking to diagnose a current or recent rubella infection. And that would only be if the woman was exposed to rubella or displayed rubella-like symptoms. The reason is because of the risk of false positives. If rubella IgM is incidentally detected in a pregnant woman, in the absence of a history of rubella-like illness or contact, you really need to do some further investigation. In people with no or low risk of exposure to rubella, the reactive IgM is likely falsely positive due to rheumatoid factor or other antibodies to infection which can cross-react with the assay.
And what's the deal with the different stratifications of rubella immunity? I've seen it reported as rubella non-immune, low immune, and immune. What does this all mean?
Okay, so non-immune and immune are pretty straightforward. If the IgG antibody level is less than 10 international units per mil, then the woman is not immune to rubella and she should receive the rubella vaccine more than 28 days prior to conception or immediately after birth. She should also be advised to avoid contact with any person who has confirmed or suspected rubella for 6 weeks from the onset of their disease. If the IgG is greater than 30, then the woman is considered immune and vaccination is not required. The grey zone tends to be where the rubella antibodies are between 10 and 30. In these circumstances, a person would be considered rubella low immune. IgG levels greater than 10 are usually considered protective against infection, but women with low antibody levels, so under 20 or 30, may rarely develop rubella infection if exposed, although there is a very minimal risk of fetal damage. The other consideration for women with low immunity to rubella is that the antibody level is likely to drop further to non-protective levels either during the current pregnancy or before the next pregnancy. So this is why we offer women who are rubella low immune the MMR vaccine. Now, it's important to know that the exact antibody levels for the cutoff of immunity varies by lab. So while we use 30 international units per mil, the lab that you use will typically report whether a patient is considered immune or not based on their own data.
All right, so let's talk a little bit more about the rubella vaccine.
The rubella vaccine is a live attenuated vaccine, meaning that it contains a small amount of the weakened rubella virus. The benefit of this type of vaccine is that just 1 or 2 doses of the vaccination can give you lifelong protection. Live vaccines typically don't cause rubella, although they can cause infection in patients who are immunosuppressed, and so they should be avoided in these people. In Australia, the rubella vaccine is only available in combination with other vaccines, such as the measles, mumps, and rubella vaccine. Common names for these vaccines include MMR2 or Priorix. The rubella vaccine can also be given in combination with measles, mumps, rubella, and varicella in vaccinations known as Priorix Tetra or ProQuad. The MMR vaccine is included in the National Immunisation Program and is routinely administered to children at 12 months and 18 months for free, as well as to pregnant women or those considering pregnancy.
So in Australia, we have quite a high uptake of the MMR vaccination, meaning that the number of women who are susceptible to rubella is quite low, but it's definitely not zero. Because of this vaccination program, less than 2% of women are susceptible to rubella infection. However, this rate rises to 4 to 8% in immigrant women. In regions where vaccination rates decline, we start to see an increase in rubella infections and thus an increased risk to babies.
We mentioned before that we shouldn't give the MMR during pregnancy, and also that a woman should avoid pregnancy for 28 days after the MMR vaccine. Why is that? And what do we do if a woman accidentally receives the MMR while she's pregnant?
Because the rubella vaccination is a live attenuated vaccination, there is a theoretical risk that the rubella virus may cross the placenta and infect the fetus, and women are advised to avoid pregnancy for 28 days following vaccination. Despite this, there has only ever been 1 report of congenital rubella syndrome from the vaccine strain, and multiple other studies have not identified cases of congenital rubella syndrome in infants born to mothers who were vaccinated between 2 weeks before and 6 weeks after conception. Therefore, if a woman inadvertently receives the rubella vaccination immediately prior to or in early pregnancy, she should be reassured and not recommended to terminate the pregnancy. Now, as you all know, most women get their antenatal bloods during pregnancy, and so we may not find out that someone is not immune to rubella until they are already pregnant. Obviously, we would avoid the MMR vaccination during pregnancy, but in these cases, we usually administer the MMR vaccination as soon as possible after the baby is born. This is usually done in a hospital setting.
Is the MMR vaccine safe in breastfeeding?
Absolutely. There's no reason you shouldn't breastfeed after the MMR vaccine.
Now, I thought I read somewhere that there can be some kind of interaction with the rubella vaccination and blood products. Is that right?
Interestingly, there are some reports that the MMR vaccine may be less effective if administered with blood products. In an ideal world, we would wait about 6 months after a blood transfusion or platelet transfusion before administering the MMR vaccine. However, in practice, this often means the postpartum woman doesn't end up getting the vaccine at all. A better strategy is to administer the MMR shortly after birth, regardless of the administration of blood products, and then check her rubella immunity 3 months after vaccine to ensure it worked. Note that there is no issue with washed red blood cell transfusions or anti-D immunoglobulin. Although the guidelines in the USA suggest checking rubella immunity 3 months after vaccine because of a theoretical potential for blood components, including anti-D, to interfere with the vaccine response.
Some women will fail to develop protective rubella IgG levels following MMR vaccination. If they've only received 1 dose of MMR, the dose should be repeated and repeat serological testing performed 3 months later. If at that point the rubella IgG is still inadequate, then the woman should be managed if she's non-immune and it's unlikely that further vaccinations will help. Management advice for subsequent pregnancies includes ensuring that all close contacts are rubella immune, minimising contact with people suffering from a rash illness, and investigating episodes of contact with rash illness or rubella-compatible illnesses in the mother. Serology, rubella IgM and IgG, and the virus detection by rubella PCR might be helpful.
Wait, how do we even diagnose rubella?
Well, rubella can be diagnosed by a 4-fold rise in IgG titer between acute and convalescent serum specimens, the presence of rubella-specific IgM, or a positive rubella culture. Serum should be obtained within 7 to 10 days after the onset of the rash and repeated 2 to 3 weeks later. Rubella may be cultured from nasal, blood, throat, urine, or CSF specimens. It's really difficult to diagnose an infected fetus based on ultrasound alone, since the nature of the malformations seen with congenital rubella syndrome are typically not visible on scan. If a woman gets rubella infection in pregnancy, especially before 16 weeks, she should be offered pregnancy termination. There is no definitively beneficial in utero treatment available for exposed or affected fetuses.
Okay, so that wraps up this week's episode on rubella in pregnancy. Let's revise what we've learned. Rubella is a highly contagious viral infection transmitted through respiratory secretions. It may be asymptomatic or present as a viral illness with an associated rash that starts on the face and spreads to the trunk. The rash usually lasts about 3 days. Key clinical findings include Forsheimer spots and lymphadenopathy. Complications in adults are rare but may include encephalopathy, thrombocytopenia, and symmetrical arthralgia or arthritis. There is no treatment for rubella and management is symptomatic only.
Rubella infection in pregnancy can result in complications including miscarriage, stillbirth, fetal growth restriction, preterm birth, and congenital rubella syndrome. Rubella crosses the placenta and infects the fetal bloodstream, resulting in damage to blood vessels, causing end-organ ischemia, and direct cytotoxic effects, causing cell death. The severity of congenital rubella syndrome depends on the timing of infection during the pregnancy.
Infection in the first trimester has an 85% risk of transmission to the baby. Infection in the second trimester has a 25% risk of transmission, and infection in the third trimester has a 100% risk of infection to the baby. The severity of congenital rubella syndrome also depends on the timing of fetal infection. Infection in the first trimester is associated with cardiac defects and eye defects, and hearing loss can occur with infection up to 18 weeks. After 18 weeks, the chance of birth defects is low. However, the baby is still at risk of fetal growth restriction and late manifestations of congenital rubella syndrome, such as the endocrine abnormalities.
Rubella can infect all cells of the fetus, leading to significant birth defects and a condition called congenital rubella syndrome. Congenital rubella syndrome refers to a combination of birth defects associated with rubella infection in pregnancy. Key features include heart defects like a patent ductus arteriosus or pulmonary stenosis, eye defects like cataracts or microphthalmos, brain defects like developmental delay and microcephaly, and sensory neural deafness. Late manifestations include diabetes, thyroid disorders, precocious puberty, and extended rubella syndrome. Babies with congenital rubella infection are contagious for up to 1 year after birth.
The incidence of rubella in Australia is low, and there's definitely no local spread of rubella within Australia. Despite this, susceptible women may still get infection from overseas travel or exposure to people travelling from overseas. 4 to 8% of immigrant women and less than 2% of white women are susceptible to rubella. Testing for rubella immunity before pregnancy and vaccinating if needed is important for protecting women and their unborn children against rubella. Remember to only test for IgG and not IgM, unless you're trying to exclude a current infection. This is because of the high risk of false positives.
Rubella immunity can be classified as non-immune, immune, or low immune. Women who are non-immune or low immune should receive the MMR vaccination 28 days before pregnancy or immediately after pregnancy. The MMR vaccination is only available in combination with measles and mumps or measles, mumps, and varicella, and is called Priorix, MMR2, ProQuad, or Priorix Tetra.
The rubella vaccine is a live attenuated vaccine and should therefore not be administered to people in pregnancy or who are immunosuppressed because there is a theoretical risk of causing infection in these patients. Despite this, there's only ever been one reported case of fetal rubella infection after the MMR vaccine, and so women who inadvertently receive the vaccination around or during early pregnancy should be reassured that the pregnancy is unlikely to be affected and that they do not require termination.
The MMR vaccination is safe in breastfeeding. However, it may be less effective if it's administered with blood products. If the MMR vaccination is administered in close proximity to blood products, the rubella status should be checked at 3 months to confirm successful immunisation.
And that sums up this week's episode on rubella. Thanks for listening to our episode on the uterine sound. You'll find our summary slides on Instagram later in the week, and feel free to check us out on our website, theuterinesound.com, or email us at theuterinesound@gmail.com. Thank you.
Yippee!